Hello, my name is Dr. Patel, and I'm a second-year internal medicine resident at Oklahoma State University Medical Center. Today, I would like to present an interesting case of atypical hemolytic uremic syndrome in a setting of recent bacterial illness. First, I would like to recognize all authors who contributed to this case report presentation equally. The patient's information has been removed to protect the patient's privacy. All identifiers have been removed as well. Atypical HUS is a rare syndrome of HUS, which is commonly associated with a combination of hemolytic anemia and thrombocytopenia and renal injury. The disorder is mostly found in children. The disorder is mostly associated with Shiga toxin E. coli producing bacterial illness. Atypical HUS is 10% of all HUS. Atypical HUS is atypical in that it is not all caused by bacterial illness, but rather by mutation or autoantibodies leading to dysregulated complement activation. Atypical HUS can cause similar symptoms at HUS, but does not necessarily need to follow bacterial illness. Atypical HUS is subcategories of how it is identified. These subcategories are broken down into two categories, including familial, which are mutations in the complement cascade, and sporadic, which are further broken down into idiopathic, pregnancy-associated, HELP syndrome, drugs, organ transplantation, HIV, or cancer. The diagnostic criteria of atypical HUS is thrombocytopenia with platelet count less than 150,000 or less than 25% from baseline, microangiopathic hemolytic anemia that are seen with schistocytes and or elevated LDH. And 3, end organ damage can be seen in renal manifestation, neurologic symptoms, or GI symptoms. Other rare organ damage, including pulmonary symptoms or cardiovascular symptoms, can occur. Inciting factors that can cause atypical HUS include pregnancy, autoimmune disease, bone marrow transplantation, plasma exchange, cytotoxic drugs, Shiga toxin, solid organ transplantation, acquired complement mutation, HIV, or cancer. This is a 66-year-old woman who presented to the ER from an outlying hospital for nausea, vomiting, diarrhea, shortness of breath, reflux, weakness that began 1 week prior to presentation. She had a past medical history of insulin-dependent type 2 diabetes mellitus, depression, hypothyroidism, and essential hypertension. She did endorse 3 bright red blood movements per day and noted bright red blood per rectum throughout the week prior to her presentation at the hospital. Labs were pertinent for white blood cell count 21.1, platelets 59, INR 1.4, sodium 133, chloride 112, BUN 65, creatinine 4.91, phosphorus 2.1, lactic acid 5, LDH 1,763, positive fecal alcohol blood test, C. diff PCR negative. Patient had suspected colitis per CT imaging at outlying facility and was treated with vancomycin and flagyl for C. diff colitis. Patient tested negative for E. coli 0157 and Shiga toxin. Patient was also noted to have acute renal injury and was diuresed due to high volume status prior to transfer to OSU-MC. Upon arrival, she was anxious and aphasic and underwent CTA imaging for stroke, which was negative. Neurology was consulted for a witnessed seizure in the hospital. EEG and MRI were obtained, which did not show signs of seizure activity. Due to worsening renal function, hemodialysis needed to be initiated. The combination of uremia, anemia, with hemolysis, and schistocytes present on peripheral smear, neurologic symptoms, with intermittent low-grade fever, patient was treated with plasmapheresis for presumptive treatment of TTP. Adams TS13 was ordered, which was returned normal, and plasmapheresis was discontinued. Interventional radiology was consulted for renal biopsy in conjunction with nephrology, which showed acute tubular necrosis, microangiopathy consistent with atypical HUS. Patient was started on eculizumab or Solaris and was pre-medicated prior to treatment due to worsening mentation. Because of the worsening mentation as well as low intermittent grade fever, an LP was performed which showed elevated protein and glucose likely contributed to diabetes. HSV IgG was positive, which was treated with prophylactic acyclovir. Patient did have seizure-associated anxiety, which was diagnosed by psychiatry in an inpatient setting. Patient was discharged with hematology-oncology, nephrology, neurology, followed up in an outpatient setting, and completed treatment with revoluzumab in an outpatient setting. Attached are pathology slides with H&E stains showing the axial sclerosis and acute tubular necrosis with erythrocyte fragmentation consistent with atypical HUS. This patient ultimately tested negative for E. coli 0157 and Shiga toxin, which are mostly related to HUS. Atypical HUS can also have been incited in the same bacterial illness, but it is not the cause like it is when it comes to HUS. There are various causes of atypical HUS compared to HUS in general. This patient is undergoing genetic mutation testing and complement testing for further evaluation of atypical HUS. Our references are below. We would like to extend a special thanks to OSU Internal Medicine Department for allowing us to participate and share this report with the Oklahoma ACP. Thank you for your time.